Hi, everyone. I'm Erika Del Sordo. Welcome to today's Talk with Erika. Thank you so much for being with me. I have another fantastic show today. We've got Dr. Jay Harness, and you could subscribe to my YouTube channel and my Anchor podcasts, Google Podcasts, Apple Podcasts, and more to find this interview amongst all my others. Dr. Jay Harness is a clinical professor of surgery at the University of California, Irvine, and a breast surgeon at both St. Joseph Hospital in Orange, California, and Northern Inyo Hospital in Bishop, California. Now, over the years, Dr. Harness has been known for his work in the fields of endocrine and breast surgery, as well as the use of ultrasound in surgical practice. He has authored over 100 scientific articles and book chapters and has been the lead editor of 3 textbooks. His most recent books, the Breast Cancer Answers book, which we'll talk about, and Operative Approaches to Nipple-Sparing Mastectomy, Indications, Techniques, and Outcomes, were published in 2016. He is a co-founder and medical director of Breast Cancer Answers. That's breastcanceranswers.com, which is a social media video site for breast cancer patients, family members, and friends. Now, welcome, Dr. Jay Harness. How are you?
Hey, Erica, it's so good to be with you. I mean, it's really a treat to be with you, and thank you for your very kind introduction. That was very sweet. Thank you.
You're welcome, and you have so much more, and I wanted to make mention that I literally could have gone on for the whole 30 minutes of our podcast about all the things that you have done, because you are just amazing. You have so many degrees under your belt and everything. So I will post all of your credentials in the info and about me sections in the audio and video podcasts.
Well, that's very kind. Thank you very much.
You're welcome. So let's get right into talking about your book. You've got a new book out, and I think that survivors and previvors alike should be reading this.
Oh, you're very sweet. So let me hold it up to the camera. Hopefully we can all see that. It's called The Breast Cancer Answers Book, Your Guide to Achieving Emotional Reconstruction. As far as I know, Erica, this is the only book co-written by both a physician expert and a long-term breast cancer survivor. There have been many books written by physicians, of course, and many books written by survivors, and including, by the way, your cousin Cindy, whose book I've got right here as well. And but this is the first I know of co-written by both a doc and a patient. And what we try and do in this book is really describe the journey. And one of the important points I want to make today is that breast cancer is really a lifelong journey. Does that make sense?
It does. Yeah.
You know, people think, oh, just operate, get rid of this thing, and I'm going to be done with the whole thing. And whoops, that's just one little part of what we've got to do to treat people.
Mm-hmm.
The other really important message to get out is that breast cancer really requires what's called a multidisciplinary team to provide adequate treatment.
Okay.
You know, years and years ago, back, let's say in the 1970s when I was being trained, breast cancer was simply looked upon as a surgical disease. One size fits all, you get a mastectomy, get your lymph nodes taken out, see you later. Chemo was starting to come in, anti-hormone therapy was starting to come in, and then we get into the mid-1980s when all of a sudden we now had the option of saving women's breasts based on important clinical trials. Well, to do that adequately and to talk about options, it's way more than just a surgeon. It's a medical oncologist, it's a radiation oncologist, it's a breast radiologist, it's a breast pathologist, it's physical therapists, it's social work. I mean, it's a multidisciplinary team. And the good news is that in most metropolitan areas, certainly in the United States and pretty much in Western Europe, you've got teams like this assembled. So one of our messages for the folks watching your podcast today is, if you know anybody diagnosed with breast cancer, make sure they're in the hands of a multidisciplinary team. Does that make sense?
That makes complete sense. And I'm happy that you mentioned that, because a lot of people may not know that. A couple personal friends of mine who were just actually treated for breast cancer were looking for answers because it's not readily out there. And they got Cindy's books. I made sure that, they got a copy of those, but it's not readily available. So that's very good information to tell people.
Yeah, and we've got another site that people can go to. It's a social media site I think you mentioned in the intro called Breast Cancer Answers with an S.com.
Mhm.
We've got about 1,300 videos there. And the last time I looked, we had just surpassed about 12 million views of our videos. And the
Wow.
videos are organized and broken down into newly diagnosed, medical oncology, surgery, radiation therapy, et cetera, et cetera. Here's the other point,
Mhm.
because I get asked this all the time. Oh, gee, Dr. Harness, mammograms, I hate having mammograms done. Obviously, it was a technology invented by a man, the way it squeezes your breast. And listen, Erika, if I don't put some humor into what I do, I'd be shooting myself at the end of the day.
Understood.
Yes,
Understood.
obviously it was invented by a man. But the bottom line is, if we took 1,000 people whose cancers were detected by screening and played those and matched those against 1,000 patients who walked in the doctor's office with a lump in their breast, what do you think the difference is?
Hmm.
Yeah, difference
Significant.
in survival, okay?
Yeah.
It's also a difference in the extent of, let's say, even surgery that might be needed.
Right.
The other thing that's really hard for patients to understand is that the cancer in the breast per se doesn't kill anybody. It's the cells that can circulate out of the cancer that circulate around the body. It's like opening the window here and throwing grass seed out the window.
Mhm.
It's where those cells can land in your lungs, your liver, your bones, your brain. That's where the real threat is.
Mhm.
So we've known, again, since about the last 35 years or so, that surgery is just one little part of what we're doing here. You have to treat the whole body if you have any kind of what we call invasive cancer, meaning that the cancer cells have grown through the walls of the ducts of the breast or the lobules of the breast. That's a really hard concept for patients to understand. They come in to see me typically as the first visit after being diagnosed and say, are we operating tomorrow or the day after tomorrow? And I say, time out. We need to know a lot more about your cancer. We need to know what the markers are. We need to know more about your family history. There's a small chance you could be carrying a breast cancer gene.
Mhm.
And on top of everything, we have multiple options now for treatment from a surgical perspective, let alone the other things we do. Frankly, it generally takes me 2 to 3 visits before we finally decide on what's going to be the initial best of treatment approach. And also in my institutions, we talk and present cases at tumor boards where you have the whole group coming together discussing patients. And that should be another thing people should be asking for. Gee, Dr. Jones, did you present my case to a multidisciplinary tumor board? Yes, no. What? What's the story here? We want all of this input, Erika, to really make good decisions. So one of my other really favorite expressions is time is our friend.
Mhm.
Because the only enemy when you're newly diagnosed is up here. It's the normal fear and anxiety that people have. But the reality is that that cancer has been there for months and months, and in some cases, a few years to develop. And so we just, again, don't go running off to operating rooms. We want to make decisions about what's the best personalized treatment for you as an individual patient. Now, I've been talking way too much here. This is your broadcast. But
You know what? You're the expert.
well, thank you. But I just wanted to get those really key points in right up front and early on, okay? As a breast surgeon, I'm a general surgeon by background. I'm typically the first referral. In other words, a primary care family physician or whoever, maybe the patient walked in and said, gee, I got a lump in my breast. Usually that physician begins the workup. The workup should include mammograms. The workup should include an ultrasound. And most importantly, if there's something suspicious that's there, the workup should include an image-guided needle biopsy.
Okay.
Not running off to an operating room like we did 40 years ago and excising the lump out to find out what it is.
Mhm. Mhm.
For the last 25 years or more, We do ultrasound guided or X-ray guided core needle biopsies to find out what a suspicious area is. It could be benign or it could be malignant. That gets the process rolling, okay?
Hmm.
And it tells us, let's say hypothetically it's a cancer, but then we want to know, is it a ductal cancer? Is it a lobular cancer? What's the grade of the cancer? What are the markers on the surface of the cancer cells, like the normal female hormones, estrogen and progesterone, or a HER2 new marker, which is a specific abnormality? We want to get all of that data and information back to even begin the process of talking to a patient. Does that make sense?
It does. Yep. It makes complete sense. You have to.
Yes. And as a good example, if somebody ends up being triple negative,
Hmm.
meaning the estrogen receptor is negative, the progesterone receptor is negative, and the HER2 new is negative, that's one of the most aggressive forms of breast cancer. We go to immediate upfront chemotherapy.
Okay.
Or if the cancer comes back, what was called HER2 new positive, again, 9 times out of 10, we're going to go to upfront chemotherapy combined with a Herceptin-like drug, because remember what I said, the most important thing are those cells that have circulated outside the body. That's actually the higher priority than it is the lump in the breast, number one.
Hmm.
Number two, with those two particular forms of cancer and chemotherapy up front, we can often melt the cancer away in the breast itself. Anywhere from 30 to 40% of the time, it just literally can disappear. It can have what's called a complete pathologic response.
Okay.
Then down the road can change the surgery. In other words, if somebody has a pretty good sized lump and we can literally shrink it down up front, we may be able to preserve the breast and not necessarily have to do a mastectomy. Okay.
Okay.
So all of that data is important. And that's one of the things I spend my most time on that initial visit with patients, saying, okay, time out, settle down. I know you're scared to death, but you and I and your family always insist that other family members are there. We need all of this information to decide what's the best route for you.
Hmm.
And if you walk in the door and say, oh, by the way, my sister and mother and grandmother had breast cancer, we go, whoops, or ovarian cancer, we go, whoops, we need to get you into the hands of a genetic counselor to find out if you might be one of those not quite 10% of patients carrying the gene for breast cancer around, because that's going to impact what we're likely to recommend in the way of surgery and other forms of treatment.
Hmm.
It's
I'd
a
imagine. Yeah.
it's a it's a complex process. It really is.
It really is, and it's hard to make, people go in, they're afraid. That's so hard to, well, relax, we'll take care of it. We need to do this all methodically, and internally people are having an inner heart attack. It's just, that's a tough one.
It is, and I've been at this 35 years dealing exactly with what you're talking about. And so one of the things that I need to do is to embrace their fear.
Hmm.
Look them straight in the eye and say, we're going to take care of this. But we have to take care of this in an intelligent way, not in an emotional way of running off and, as I said, taking your breast off tomorrow. One of the knee-jerk reactions of patients is, I just want both my breasts removed.
Yeah.
And I go, wait a minute, time out. Let's learn more about your disease, et cetera, where we jump to that sort of conclusion.
Hmm.
Another misperception is, Dr. Harness, I just want the biggest operation you have, because if I have the biggest operation you have, I'm going to do better. Not true.
Right.
It's about the biology of the disease, Erika.
Hmm.
That's why it's so important to learn all these factors up front, to have a multidisciplinary team, and to approach the whole treatment in an intelligent, scientifically based way. Okay?
Yes, multidisciplinary team. I'd like to make sure that people hear that, because that's exactly what, if you're going in for surgery, you need to be asking the right questions. You need a multidisciplinary team. So that
Yeah,
should be in their vocabulary.
yeah, absolutely. Remember, the other members of the team besides the surgeon are a medical oncologist. Medical oncologists, everyone, I mean, I deal with fear all the time. So people come through the door and say, oh my gosh, am I going to need chemotherapy? Because the first thing they're thinking about is, and I've got an itchy nose, first thing they're thinking about is, am I going to lose my hair? Am I going to lose my eyebrows?
Right.
Lose
Right.
my eyelashes? Oh my word. Of course, they're all,
Legitimate concerns.
oh, I am, well, this gorgeous hair you got, come on, of
Thank
course.
you.
Of course it is. And of course, number one thing is, am I going to survive all this? And the answer is, yes, you are going to survive all this. And another really important message is this. We want to give you today the state of the art care as we understand it in 2020 to make sure we get you well down the road. Because I know, having been at this 35 years, that in the next 2 years, 3 years, 5 years, 8 years, we're going to learn a lot more. We're going to have a lot more improved therapies, et cetera, so that if your cancer should come back down the road, we have gotten you that far down the road to have those new therapies available to us. Does that
Mhm.
make sense? I hope.
That makes complete sense. You're seeing not just people going through this in California, but I'm assuming you have patients who come see you from across the nation, maybe the world. Is that right?
Occasionally, my
Okay.
main focus is California, but I've been on the internet since 2011 with Breast Cancer Answers. And so, and I do lecture nationally and internationally as well. I have this textbook out that you referred to on nipple sparing mastectomy, and I want to talk about that in a minute.
Hmm.
And actually, I'm part of a team that teaches courses both here in the US and internationally on how to do that particular technique.
Okay.
Let me throw out another whole concept to you. It's called oncoplastic surgery. Whoa, what does
Oncoplastic
that word mean?
surgery.
Onco, cancer, plastic surgery.
Hmm.
It's a term actually developed in Europe, probably close to 20 years ago. And the concept is this. We want to do the right cancer thing surgically, onco,
Hmm.
but we want our patients to look good, plastic. Okay?
Okay.
Okay, so let me give you a classic example. I have a woman with a double or triple D breast size. Bra straps have been cutting into her shoulders for years. And she's found to have, oh, the little printer is going off right next to me here. How delightful. Uh, and she's been miserable for years with her big breasts, and her cancer is found through screening,
Okay.
tiny little cancer. And I actually kind of get a smile on my face and say, have I got a deal for you? I'll bet you've wanted to be smaller and perkier, right? Oh, yeah, absolutely. But I've never been able to get anybody to pay for it. Well, we can do your lumpectomy as part of lift reductions. And at St. Joseph Hospital in Orange, California, we also do intraoperative radiation therapy. So you can literally go to the operating room, have your lift reductions done on both sides, your cancer taken out, your lymph nodes checked, and your radiation therapy received, and you're out the door.
Wow.
All right. So part
Wow.
of this, so another part of this oncoplastic philosophy is we want you to look good. And
Hmm.
so even with lumpectomies, we're trying to limit our incisions with lumpectomies to around the areola, coming in from underneath the breast or coming in from the axilla, the armpit area,
Hmm.
so that we hide the incisions. So it isn't obvious that you've had breast surgery done to you.
Right.
Internally, we can move tissue around to sort of reshape the breast a little bit. So the bottom line is this. After this sort of approach, when you're standing there getting out of the shower and looking at yourself in the mirror, we want you to see something good. We don't want to see the horrors that we had with radical mastectomies of 40 and 50 years ago, which is another reason why patients should be involved with surgeons like myself who do breast cancer work all the time and a multidisciplinary team, which also includes a plastic surgeon.
Right. Okay. That's very good to know. This is such a wealth of information. I did not know this myself. So you're really helping me and everyone else listening and watching.
Well, good.
Yes. That's great to know. A lot of people probably did not know that that is an option.
Yes. So the new term for people besides multidisciplinary team,
Right.
the new word to go around and ask their breast surgeon is, do you do oncoplastic surgery?
I like that. Okay. Oncoplastic surgery. We got a
Onco,
lot. There's going to be a quiz later.
yeah.
Multidisciplinary team and oncoplasty surgery.
Oncoplastic surgery.
Oncoplastic. Okay.
Oh, like oncology. Think of oncology.
Oncology and plastic surgery.
And yeah, combined together by the surgeon. So yeah, absolutely.
Okay. Okay. You got a big team over there, by the way. What does your team entail?
I'm primarily at St. Joseph Hospital in Orange and also at a small critical access hospital up in Bishop, California in the Eastern
Okay.
Sierra. Our bigger team is at St. Joseph Hospital in Orange. We've got everybody that I've been listing already that are all specialized in breast cancer work. Out in the Sierras, out in the Eastern Sierras, in the United States, we have about, I think it's 12 or 1,300 what are called critical access hospitals.
Hmm.
These are out in rural America. Most of them are very well equipped, which is the case for me at Northern Inyo Hospital in Bishop. And so I have everything I need on site. I do not have a plastic surgeon there. And in these kind of remote areas, you're not going to expect to have radiation therapy and nor medical oncologists.
Hmm.
However, at both Bishop and Mammoth hospitals, which are about 30, 40 miles apart from each other, we in fact can do chemotherapy on site once it's ordered by an outside medical oncologist. So we work with a cancer center up in Carson City, at the Carson Tahoe Cancer Center in Carson City, Nevada, to about 3 hours to the north. And we work with our wonderful City of Hope, one of their branches down in Lancaster, about 3 hours to the south. And so even for folks out in rural America that may be actually watching your broadcast, there are ways of having access, if you will, to a multidisciplinary approach to the treatment of breast cancer. And frankly, Erika, multidisciplinary teams are now important for the treatment of all cancers, whether it's colon cancer, lung cancer, lymphomas, you name it. Typically, it's a multidisciplinary team. Okay.
It comes as a package. If someone's dealing with that, it's kind of like a package deal that you have a multidisciplinary team.
You should, and you should be asking for it.
Hmm.
And you should be asking, have my cases been presented to a tumor board? And let me explain what a tumor board is.
Hmm.
This will be part of our pop quiz at the end of our broadcast. Typically, a tumor board is a gathering of all the specialists, particularly the medical oncologists, the surgeons, the radiation oncologists, the pathologists, and the radiologists. And you do this for melanoma, you do it for breast, you do it for colon, head and neck cancers, all of them.
Hmm.
The idea is this: prior to starting any kind of therapy, you want to present the case to the team. Here is Mr. Smith. Mr. Smith's got X, Y, and Z.
Hmm.
You review the slides because, frankly, the biopsy may have been done elsewhere. So we have the patients bring their slides with them so that our pathologists review to make sure the diagnosis is correct.
Right.
You want to also have patients who have been diagnosed outside bring with them their imaging studies,
Hmm.
their mammograms, their ultrasound, their MRI exam, whatever it is, and you review all of those. And then typically at the tumor board at St. Joe's Hospital that I ran for many years, we also have research people there.
Hmm.
And say to the research people, okay, is this person, this set of circumstances, eligible for a possible clinical trial that we're in cooperation with regionally and nationally? Yes or no? And you see, that begins the process. And we also have physical therapists there who may want to see the patient up front before anything further is done to do an assessment of their physical activity and to do an assessment of range of motion or other kinds of things. And then particularly after any kind of breast surgery, and particularly where we're taking lymph nodes out, we always have a small concern about swelling of the arm called lymphedema. And so many departments, including both hospitals that I'm at, have specialists in lymphedema who will then see patients down the road, post-surgery, post, let's say, radiation therapy, whatever, to evaluate and make sure somebody isn't developing lymphedema. And we have diagnostic ways now of finding lymphedema before it's even clinically apparent and start treating it aggressively. Does that make sense? That's where these team members all come together. It isn't just get your surgery done and see you later and what have you. Now, remember I said right up front, this is a lifetime journey.
Right.
So somebody may get through their first year of treatment, everything's doing great. And if they're estrogen receptor positive, which is usually about 80+% of the cases, the typical invasive estrogen receptor positive patient is on a pill that she takes once a day, generally for 5 years. That's to help churn off any estrogen positive cancer cells that may be lurking elsewhere in the body, okay?
Okay.
Then I tell patients, look, the first 5 years, if you're estrogen receptor positive, that's good.
Mm-hmm.
But the next 5 years is even more important. And the next 5 years after that is even more important. Because believe it or not, in my world of breast cancer and estrogen receptor positive breast cancers, unfortunately, we can see cancers reoccur elsewhere in the body 5, 7, 8, 10, 12 years or more down the road. So that's part of that lifetime journey and follow-up.
Okay.
All right?
Okay.
And second of all, if we've done, the other breast is still there, there's a small risk, small increased risk of a completely unrelated cancer developing in the other breast over the typical average.
Okay.
So that other breast has to be followed literally for a lifetime. Or if we did a lumpectomy with radiation therapy, maybe 8, 10, 12, I've got patients 15, 18 years down the road, they have a brand new separate cancer in the originally treated breast.
My goodness.
Okay, so that's where I'm saying this lifetime journey is really critically important to patients.
So it's no longer when, they finish, they ring the bell, I'm cancer free. It's still a lifetime journey of everything that you're talking about. It's not just over and done, and that's the end of it.
Yeah, you got it, kiddo. And that's really true. And particularly in these invasive cancers, there's a whole big mystery out there of cancer cells going to sleep elsewhere in the body, hibernating, if you will.
Right.
Like a bear that's sitting in a cave for a few years and then something turns them back on. Hey, listen, if I could answer what's going on scientifically, I would invite you to join me when I pick up my Nobel Prize in medicine, okay?
Okay. Okay.
Don't get your tickets yet.
That's too funny. I know exactly what you're talking about because just this past, we're going through a pandemic and everything. Just this past spring, I had a cousin of mine, slightly older than me, but she had female cancer and it had spread different places, thyroid, lungs, etc. And it went away. They got it. They removed the female organs. They removed all of the cancer. And then boom, a flipping brain tumor, and one that was so spidered out, she passed. And it's like, you're going, what on earth happened here? And it's exactly what you're explaining.
Yeah. And, when Halsted invented the radical mastectomy in the 1800s, Halsted's concept was that cancer, no matter what the cancer was, spread in concentric circles, like dropping a pebble into a pool of water and the circles would get bigger and bigger. So Halsted's concept was all of the breast, all of the lymph nodes, big, huge radical operations. And what we now know all these years later is no, once the cancers can grow through what is called the basement membrane, is the lining of where cells are, it's sort of like me opening the door here or the window and start throwing stuff out the window or out the door. These cells circulate around the body, and unfortunately, areas like the brain, like your cousin, I think you
Hmm.
said, friend.
Yes. Yes.
And yeah, and so that's part of what we're working on is develop therapies to go after those what are called circulating tumor cells. Okay,
Hmm.
and we do have ways in this day and age of actually measuring that cells can circulate around. And there's a whole huge effort now in identifying those sorts of cells, figuring out earlier treatments, et cetera, et cetera. I do want to talk. I know we've been at this for about a half hour or so, which is a pure delight to be with you. But in the last few minutes, I want to talk about the COVID pandemic.
Okay.
Okay?
Hmm.
Because
Please.
it's really germane right now. A couple of things are going on.
Hmm.
When the pandemic really began, we all collectively shut down, if you will.
Hmm.
We stopped doing screening mammograms. Well, I didn't go to the OR for virtually 2 months because we were really worried that we had enough protective gear for people. Literally, everything started shutting down. Things are now starting to open back up, particularly for screening or follow-up mammograms.
Hmm.
But one of the things going on is people are afraid, Erika. They're afraid to go over to their screening center or afraid to go to the hospital
Yep.
or even afraid to go to their doctor's office because they think, oh my gosh, if I go there and somebody's COVID positive, I'm going to pick it up and I'm going to be ill, et cetera, et cetera.
Hmm. Hmm.
So breast cancer screening centers are standing on their heads right now, cleaning everything, spreading people out. So we are doing screening again, and
Okay.
then typically after a lumpectomy, we see patients once a year for new updated mammograms to be looking to see if anything has reoccurred in the treated breast. And we're also obviously carefully screening and looking at the other breast to make sure there isn't something there. So, of your viewers of this podcast, please set your fear aside, contact your mammography free center, and make sure that they're all set up. You'll need to come in with a mask on, but everybody is absolutely standing on their heads right now.
Hmm.
Now, in the early days, the first few months of this pandemic, there was a huge outpouring of all the specialists in the United States trying to figure out what to do with newly diagnosed cancers,
Hmm.
particularly breast cancers.
Hmm.
Well, the good news was in the newly diagnosed, if they were estrogen receptor positive, we could put them on anti-estrogen pills and not have to go off to the operating room. And that's called upfront or neoadjuvant anti-hormonal therapy, which we could do for many, many months. We're treating not only cells circulating around the body, but we're also treating the tumor itself, which will start to shrink.
Okay.
Or if we found those other two aggressive forms that I
Mm.
told you about, triple negative and HER2 positive, we immediately got people into chemotherapy. So again, we're starting to treat people, okay?
Okay.
Now, in most areas of the country, although the West Coast now and Southwest are such hotbeds, but in most areas, operating rooms, we've got enough of their critical supplies that most operating rooms are now open and we are now operating again. And again, we're COVID testing all the patients before they show up for their surgery to protect us, the providers, to not obviously spread anything around in an
Right.
okay?
Right.
And so all hospitals now have really strict protocols. And so if you are newly diagnosed, work carefully with that team that I talked about, but know that we have options when it comes to this pandemic, okay?
Okay. Thank you very much for everything that you have shared today. Thank you for talking about your book at the beginning. I think a lot of people need to read that. It's the Breast Cancer Answers book. I'm going to have every single link and all of the terminology that we discussed in this show so that people know where to look. Do you want to add anything before we do say goodbye? And I really don't want to, by the way. You are a wealth of information. I enjoy talking to you. You're a wonderful person, a great doctor. But we do have to, unfortunately, say goodbye to this episode. Did you want to add anything?
Not really, just to say what a pure delight it is to be with you. And the final
Thank
message
you.
I have for patients is learn as much as you can about your disease. Become an expert in your own disease. And I could probably retire, Erika, on the number of patients who have said to me, well, gee, doctor, if I were your fill in the blank, what do you recommend? My job is to give you options. And we work together making a decision what's best for you. Okay?
Okay.
So thank you for the opportunity to be with you. It's a pure delight. Remember to live life with loving kindness.
I love that. Dr. Jay Harness, thank you very much. Can't thank you enough.
My pleasure.
Thanks for listening to today's talk with Erika. Join me next week for another discussion with the experts who help make life easier. Please visit my website, erikadelsordo.com, where you'll find all of my social media platforms and more. And be sure to subscribe to my YouTube channel. Once again, thanks for listening.